Welcome to the Beauty Scientists with Dr. Kristy Hamilton and Dr. Roy Kim. Real beauty without the hype.
Hello, this is Dr. Roy Kim, and I'm here with my Beauty Scientist podcast partner, Dr. Kristy Hamilton, who went to Costa Rica, sadly without me or you or pretty much anybody else, had a wonderful time, and actually went to Motiva World Headquarters, where she learned about the Preserve technique. So, Kristy, it's great to see you. How was Costa Rica?
Great to see you, Dr. Kim. Roy, it was so much fun at the beautiful campus, and they invited us down to learn about their new, it's a philosophy, it's a set of tools, it's a technique. So it's a different way of thinking about breast augmentation, preservation breast augmentation, and they appropriately call it Preserve. And it's a really interesting technique. They've launched it globally around the world and are now introducing it into the United States. And it very much resonates with how I like to do breast augmentation. We'll kind of talk about the different advantages and disadvantages of all these techniques, but it has a hyper fast recovery, which is really nice. Although I know you and I would probably agree that we already have very fast recovery protocols. But I love the Preserve concept. I know we're going to dive into how this breast augmentation technique works.
I know, like, vaguely who the ideal candidates are. In other words, patients who need maybe less volume, who are probably primary breast augmentation, patients who don't need a lift, patients who've never had it before. But if you could tell us what exactly you're looking for, or Motiva is looking for the ideal candidate.
Yes. So it's intended to be a primary breast augmentation candidate. It can be someone looking to have just an implant or an implant with a lift, but it needs to be someone where the goal is preservation of their breast anatomy. So this means someone who has essentially normal anatomy, meaning not a tuberous breast or some other like very significant asymmetries. And it's someone who is seeking a natural look with a smaller volume augmentation. And the concept is that we are really minimizing active dissection of the pocket. So other than that skin incision, and this is obviously not including lifts, but for breast augmentation, only the incision in the fold is made, which is even smaller. And then everything beyond that is about basically if you consider like the breast tissue structures like a field of grass, we're parting the grass with their tools, creating a very defined pocket, spreading open that pocket with a balloon, which pushes all those breast structures around the implant. So it's like hugged like in this nest of support. Nerves aren't cut. Blood vessels are not cut, they're really moved. And then that is a very, very supportive environment for an implant. The fold of the breast is intact, the ligaments around the breast are intact, and you can even place this implant a little bit higher and more medially, meaning towards the cleavage, to get a little higher impact from a smaller overall volume to get the cleavage that women are looking for without having to add as much weight to the breast. I think you and I would both agree. Most when they come in, they're not like, I really want more volume on the bottom outer part of my breast. That usually has got enough. What women come in, they're like, I'd like more volume at the top and I'd like more cleavage. And so it allows you to really precisely place that implant there without augmenting the rest of the breast, which may not actually be desirable.
Right. No, that's really important. The next question I have for you, the pocket can be made under the fascia or technically subglandular, like above the fascia under the breast tissue, correct?
Yeah. So for this, the fascia will be too tight. So it's intended to be subglandular, or what they're calling in this like posterior lamellar space, the loose areolar plane.
Gotcha.
So you'll inject some numbing solution called tumescent first. It kind of pre-expands that space. This is how you would do it if you were doing it without general anesthesia. And then you confirm with ultrasound that you are indeed in the space that you're looking at, kind of like pushes the breast tissue forward. And then you place your tools in that area to make sure that you're expanding in the appropriate pocket. So it'll be a subglandular,
Okay,
like
so it is
cream.
above the fascia.
It is above the fascia, not subfascial.
Gotcha.
So I think, how are you favoring doing breast augmentation for the most part? Now, I know we do it all different ways depending on the patient.
Right now, it's subfascial, and I'm not against above the fascia subglandular. It's just that it's a very long discussion with patients in the United States because that was what we used to do, golly, like 40, 50 years ago in the 70s and 80s. And then it fell out of favor. And I don't think it's the technique. I think it's the technology of the implant.
Yeah. And so for our listeners, that plane was abandoned at the time because it was brought with what's called capsular contracture or abnormal scar tissue formation around the breast. So if you ever given someone a hug and you felt these like hard, tight rocks, that's capsular contracture. It doesn't look beautiful. And with the types of implants we had at the time, we found that we were seeing more of that if we were in the subglandular space. However, these implants are designed to have a less than 1% capsular contracture rate, even when placed in the subglandular plate. So all of a sudden, we're going to go back to a preen that makes sense for breast augmentation, but had historically been problematic with the technology that we had. So it's interesting, right? What's old is new. What's new is old, perhaps.
That's right.
But there's a reason why we wanted to place implants there. And it's because we're truly augmenting the breast. I would say also with subfascial, we're also truly augmenting the breast too. But I think that's been behind the movement towards in front of the muscle in general.
Right. So for the listeners out there, there's something known as submuscular or dual plane, where we've been placing it for a very long time, maybe 20, 25 years, under the muscle and some soft tissue. And that is fantastic for the older technology breast implants. Doesn't cause as much scar tissue formation around the implants. However, longer recovery hurts patients more because it stretches out the muscle. And really, it's technically not very anatomic. Breast tissue doesn't grow underneath your pec muscle. Breast tissue is on top of your pec muscle. So with the ability of not only going back to this older technique, which we know very well, it's been documented for 50, 60 years, but having the breast implant surface, the Motiva silky smooth surface that has no tissue reaction, like no inflammatory response or little, not forming that scar tissue around the implant, to be able to create the pocket and to deliver the implant through that tiny incision. That's really tissue preservation, the Preserve method.
So it's another take on, I think, what you and I like inherently are doing with breast augmentation, which is like preserving more, dissecting less. We want to optimize the woman's function after this operation too, and not say, hey, you can never do, push-ups or like bench press ever again. Those days are done. Now we're really augmenting the breast tissue itself, not putting in pec implants. And so, but we have the technology and techniques now where that is a viable option. So patients often ask like, okay, so what type of augmentation in general is this for? So it's people who are going to have between 150 cc's to up to 315 cc's, since it cones everything together and all that breast tissue like hugs the implant so nicely. They tend to look a little fuller than with our traditional preservation breast augmentation. So you got a little bit more oomph with the placement of the implant a little bit higher and a little bit more inward. But it's meant for smaller volume augmentations, and it has to be with the ergonomics implant because that's their like stretchier one that we can place through a really, really narrow tunnel, which is the implant that melts into more of like a teardrop shape, the more natural looking option.
Right.
So if you like that more highly augmented look, or you're looking just for a larger volume in general, then you're going to go with the way that we've been doing it with the subfascial breast augmentation.
So from the recovery standpoint, I mean, I know theoretically, patients should definitely have less pain, less downtime. What's your experience been with the patients that you've operated on?
Yeah, so it was quite amazing. Like in Costa Rica, the patient, and again, we wouldn't tell our patients to do this in the United States, but in Costa Rica, they were at the bar with us afterwards, like hours later, and they were fine. They were like, yeah, it feels like, like a chest day or like upper body workout and just a little bit sore, just taking Tylenol. They were like really fun and less swelling than we see typically with breast augmentation. So they felt and looked great, and they were just out with the girls having fun.
Yeah, that's amazing. So from from a non-ideal candidate, I think we already touched on a couple of things. Like if you want a larger volume implant, can't really get it done. If you want round implants, not really the teardrop shaped ones, you can't get it done. Are there any other considerations for patients?
Yeah, I think just patients where if their pec muscle's already been cut, you could theoretically have already had a lift and that would be okay, or a reduction, and then put in implants, that would be all right. But it needs to be someone where preserving the natural anatomy is also desirable. So someone with like really significant asymmetry, maybe tuberous breast deformity, like breast folds that maybe aren't exactly where we want them to be. So anyone where we're like not going to be preserving natural anatomy, then it doesn't make sense because you're going to have to go in and cut and rearrange and reconstruct some of those structures anyways. But otherwise, I think most people, if the implant parameters are what you're looking for, I think most people are a good candidate for this.
That's good to know. Now, the other question I have is, I was actually lucky to be in Korea this summer, and my friend actually did the first case in Korea of this, and I was able to watch it and video him. There's specialized equipment that's single-use, disposable. Is there anything else in terms of technique that is a steep learning curve? Is there a training course? Is there anything else going on?
That they're working on, they do want to have some sort of training just to ensure success. And there were 36 of us down there. And so we all operated on Costa Rican patients, which was really special experience. And we also got to watch each other operate. And so we kind of saw how people adjusted for slightly different anatomy or any challenges that they encountered in the operating room to see that. So they're still figuring out whether they're going to have surgeons go down there or if they would have you come visit with someone who's been doing it and just get to train and observe that way. But I think it's a very intuitive system once you do it yourself or see it a couple of times. So I think if you're someone who is an expert in breast augmentation like you, I think you'll find it very, very easy to add as another technique in your repertoire.
Yeah, I mean, I totally agree. I think that if you do a decent number of breast augmentation procedures in general, this is easier to understand and pick up. Of course, you should probably try out the single-use disposable equipment. But other than that, I mean, one thing I noticed in Korea is that they still put in the implant through some type of funnel device. Is that what you did in Costa Rica?
Yes, that was still the way. And I think one of the difference too is internationally, they probably had the Ergonomics 2 implant in Korea, I would think. And so that one of the differences is they can put it through an even smaller incision outside the United States. And we'll have access to that when we get the next generation of the Ergonomics implant.
Yeah. Well, I mean, this is very exciting and wonderful news. I mean, I am definitely jelly that you were able to go and I didn't go, but I'm glad that you had a great time. You learned a lot and you're able to tell all of us exactly what Preserve stands for. In other words, it is preservation of tissues. If you're the right candidate, it's like, hey, it's an amazing procedure and you can come to the bar with us after surgery.
Yes. I was like, this would never fly in the United States. I was like, we're not inviting our patients to go do like a post-surgical, like social event afterwards. But I was like, we're outside the country. This is okay. We didn't invite them. They did.
Yeah.
It's all right. But yeah, no, it was really impressive to see. And I guess we'll have to operate together, Dr. Kim, sometime so we can do some dual Preserve cases. So it'll be fun.
Yeah, that'll be a blast. Well, anyway, thanks so much for talking to us about the Motiva Preserve method, along with the insights as well as your Costa Rica trip. So for all the listeners out there who are listening on audio, please leave some comments or let us know what you thought. If you have any questions about this, please definitely fire away in the comments. And as always, Dr. Hamilton, stay beautiful.
Stay beautiful.
Thank you for joining us on The Beauty Scientists. Be sure to visit thebeautyscientists.com and learn more about modern beauty and connect with Dr. Hamilton and Dr. Kim.